Good evening, everyone. Welcome to this meeting of the Health and Adult Social Care Overview and Scrutiny Committee. My name is Councillor Patrick Canavan. I'm going to kick off by asking Democratic Services Officer if she would do the housekeeping, please.
Thank you, Chair. Please note that this meeting is being recorded by the Council for live broadcast and will be published on the Council website for a minimum of 6 months. The meeting may also be recorded or streamed for live or subsequent broadcast by members of the public, although ultimate discretion in this matter lies with the Chair in case of disruption. For those in the room, please note that if the fire alarm sounds, please exit the building by way of the nearest available signed fire exit route and make your way to the assembly point in the front car park of this building. Finally, please ensure background noise is kept to a minimum. Mobile phones and other devices are turned off or switched to silent for the duration of the meeting. And for those in the room, please, that includes turning off microphones and turning down volumes on laptops completely. Thank you.
Thank you very much. Do we have any apologies?
We've received apologies from Councillor Farr this evening.
Any substitute members?
There are no substitute members, Chair.
Okay, thank you very much indeed. Welcome everybody, and in particular welcome to the new members of the committee. Nice to see you here. I'm going to, at this point, hand over to Councillor Leslie Dedman, who's Chair of Council and Vice Chair of this committee, to deal with the item of election of Chair. Thank you.
Yes, thank you, Chairman. We're on to item 3, members. So we're looking for nominations for the election of chair for the 25-26 municipal year. And of course, each nomination has to be seconded. So, councillors, do we have a nomination? Yes, councillor.
Thank you, Chair. I'd like to nominate Patrick Canavan, please, for chair.
Do we have a seconder? Thank you. Any more nominations? No? Right. Right, councillor. I believe you're chair again. Well done.
Thank you very much.
I'll hand back over to you.
Thank you very much, Leslie, and thank you for your continued support. So we move on to item 4, which is the election of the Vice Chair for this committee for the next municipal year. Can I take nominations, please?
So nominate Councillor Lisa North. Oh, sorry.
Yes.
Yes, thank you, Chair. I'd like to nominate Councillor Lisa Northover as possible.
Thank you. Is that seconded? Thank you very much. Are there any other nominations? Councillor Northover, that makes you elected. Thank you very much. And congratulations. You're going to swap. Okay, well, we're just on manoeuvres. Can I take the usual round of declarations of interest, please? Councillor Allen.
Thank you, Chair. I'd like to declare that I have a substantive post with Dorset. No, not with Dorset. Yes, it is, isn't it? Dorset University Hospitals Trust. I forgot the name. Thank you.
Thank you. Councillor Salmon.
Yeah, I work for Dorset Healthcare still.
Thank you very much indeed. Right, we're moving on to the confirmation of the minutes, but before I ask for agreement, we do have a suggested amendment from one of the officers that was present at the last meeting. I think it's just a bit of a tidying up minute, so I'm just going to ask Louise if she would read that, please.
Thank you, Chair. It's in the self-directed support item, bullet point 4. It's been suggested that it reads, in response to a query regarding trusted reviewers, the committee was advised that they had been engaged through the Community Action Network to have conversations with people who access day services to understand what individual people would like to support their own personalised day opportunities plan, to support from existing community resources and identify any gaps which could be filled by CMEs. This supported the day opportunities strategy priority of rebalancing building-based services with community resources.
So are Is everyone happy with that amendment? Okay, and with that amendment, may I take it that we are content with these minutes? Thank you very much, colleagues. Just going to move on to the action sheet. So unless anybody has any particular points on the action sheet, I will take that as read, and we'll deal with, obviously we'll deal with the work plan a bit later on the agenda. Are there any public issues?
There are no public issues, Chair.
Thank you very much. Right, we're going to move on then to the main substantive item on the agenda this evening, which is the Access Wellbeing Transforming Dorset Community Mental Health Services. And I'm going to invite Rachel Small, Chief Operating Officer, Dorset Healthcare University NHS Foundation Trust. Thank you.
Thank you, Chair. Did you want me to share my screen? Is that the ask for the slides?
Yes, please.
I will attempt to do that whilst talking. And I think we've got 13 minutes, have we, for this item. So I will speak for a bit, but then welcome questions as well. So thank you very much for the invitation to speak this evening. I am Rachel and the Chief Operating Officer for Dorset Healthcare. So we provide community and mental health services for all of Dorset, including the BCP patch. So reason for being here is to talk about, hopefully that will share properly. There we go. Access Wellbeing, which colleagues may be familiar with. It's our transformation programme around community-based mental health services in Dorset, and we are now midway through implementing the new model. So what is Access Wellbeing? It's a new approach to community mental health and wellbeing support. I suppose historically in Dorset, we've had a number of specialist mental health services. Dorset Healthcare has been the provider of those services for many years. But we have had a gap in terms of a more universal open access offer. So we've had a sort of specialist pathway, but in view of the growing demand around mental health and a desire to make sure that we help people at the earliest stage as problems develop, we have been commissioned to open a new open access model that really aims to move mental health away from sort of the domain of purely specialists and psychiatry, but actually think about what are the ways we can support people really early in the development of a mental health problem, and also how can we support reducing stigma around seeking help and making sure we do that at the earliest point possible. This is a partnership programme, so Dorset Healthcare is the lead provider. We've been commissioned by NHS Dorset as the lead provider, but actually we're working really closely with local authority colleagues, as well as our voluntary community social enterprise sector in Dorset as well. So the new model of care that we've been implementing over the last year was very much co-produced with people using services, so local people who've used services for either many years or are newer to needing mental health support. We've worked with them in a number of ways to say, actually, what are the most important things to you? What would good care look like? How do you make that more accessible? And when needed, how do you make sure that we've got the best clinical care that follows the evidence base when a specialist input is required? We also did some piloting, so we tested before we started to scale some of the services to make sure that as we developed that offer, we were continuously seeking feedback from people, and that's something that I'll talk about as we talk through the hubs that we have developed. So the new model of care, as I've mentioned, we've not previously had an open access self-referral mental health offer in Dorset. And for the first time now, we have got what we'd call a universal offer. So anybody over the age of 18 can self-refer to the new Access Wellbeing model. They can be seen by a wellbeing coordinator. There's no need to go via their GP. There's no need to wait for a period of time to see a specialist. There are walk-in options and there are online options as well. And the aim of that is very much to look at developing wellbeing plans for people to say, what's going on for you right now? What's the most helpful thing that we can support you with? And moving away from the idea that sort of lots of assessments might give somebody some of the answers. Actually, if the driving problem, that someone is presenting with is they haven't got secure housing, we'll work them around that housing, as opposed to sort of a more clinical model, which might focus on assessments. We've also then got a layer that we call focus. So those more familiar with sort of public health land or health visitors,
we've borrowed from that model, but focused support is when somebody may have worked with a wellbeing coordinator, but actually that their needs kind of go beyond the offer a wellbeing coordinator can provide. And we would start to kind of access some of those clinical offers that exist in the system, but we've very much tried to make them more accessible. So rather than waiting on a waiting list to be assessed to access something, actually we'd move some of those resources more into the community. So things like groups around emotional regulation, that's something that could be offered more easily without having to go through a referral and assessment process to a specialist team. And then the last layer of that model is the specialist part. So for some people we know who have more severe and enduring mental illness, actually there is a good evidence base around particular treatments. It's really important that that's of the highest quality and that it's accessible for people when they need it, including that crisis care. So that specialist layer is those sort of community-based mental health teams all the way through to our hospital and inpatient care as well. What's critical about the model is it all comes together. So actually we've got the ability for a wellbeing coordinator working in a drop-in hub to have a discussion with a psychiatrist to get advice if needed, or an OT if needed, and that we're communicating together around what's the offer to an individual rather than referring somebody on and hoping that it works out. So we're really coordinating, communicating more effectively. So one of the key things is our new hubs and drop-in spaces. So some of you may have seen in the Dolphin Centre upstairs, you've got the new Access Wellbeing Hub. That's a walk-in open access offer provided by one of our BCSE sector partners. We've also got one in Boscombe as well now, and I'll talk a bit more later about the other pop-up hubs that we're developing. They're good quality premises. I think part of this is about the esteem of saying when you walk into a mental health drop-in hub, it's not premises that are kind of run down or out of the way. They're in the high street for a reason. They've been renovated to a good standard. They look professional. They're nice environments, and that's a really important message for us in terms of reducing stigma, but also making it acceptable to walk in and access help. So when someone walks into one of the wellbeing hubs, we've got wellbeing coordinators. I think there was a total of about 75 additional wellbeing coordinators recruited into the system with this investment. It's a quite significant level of investment, and they'll work with people on some of the things that are on the slide there. There's also linked to other services, like I say. So if someone walked in and said, oh, I've got a community mental health nurse and they're helping me with X, Y, and Z, with their permission, we would talk to that person and develop one plan rather than lots of different types of plans. One of the limitations is it's not a crisis service, but we have got really good connection into our mental health crisis offer if someone is in crisis and we need to escalate that support when somebody walks in. So just to give you a sense across the county, we are working with a number of partners. We've got a really good BCSE sector in mental health in Dorset. We're very, very keen to work with some of those local providers, and where somebody may have presence in Bridport, that we'd work with those in Bridport. Where there's an established organisation in, say, Bournemouth, we'd work with them. So in this side of the county, we're working with Prama, Help and Care and BCHA in terms of that provision around BCSE sector, working alongside health colleagues as well. Some of the feedback that we've had, I was in one of the hubs recently talking to someone about the difference it had made for them to be able to walk in and seek support. And actually the feedback has been really, really positive. We know in Dorset that access to mental health services has been a challenge for us in recent years. So we've had long waiting lists. We've also had people describing experiences of getting finally to the front of that queue to only be told that it's a different service that needs to help them. So actually breaking down those barriers and saying, just walk in and we'll see what we can do, is really fundamental about that sort of contracting we're doing with our public and our population around. We will be more accessible, we will meet people at where they are, and we will identify what their needs are alongside them, rather than talk about all the reasons we can't help, which has been one of the criticisms of services in the past. So those are some of the hubs and drop-in spaces. So we've got a good number and it continues to grow. So we have our fixed hubs in the shopping centres and the high street, and then we have pop-ups in a range of community locations. We've tried really hard to think about where other services are based from. So actually when you walk into a hub, you'll have the benefit of, we may have a drug and alcohol worker that's hot desking there, or Citizens Advice Bureau, etc. So we're not kind of trying to work in isolation of other community type services, and we're trying to make sure that they all sort of coalesce together a bit more effectively going forward. So these are some of the ones we've got in development for the patch as well. In particular, I think Winton will be an important development because we've not had many services there in terms of walk-in offers before. So really pleased to see that one coming online. Just to give a sense of usage. So at the moment, on average, we do have sort of between 80 and 90 people just walk into a hub at any one time. And that's 80 or 90 people that may or may not have sought help in the past, may have gone to their GP, may have gone on a waiting list that takes at least 4 weeks to see somebody. Instead, they can just choose to walk in. And we offer up to 6 sessions in a wellbeing hub. It can be flexible, it can be more, it can be less. So if you walk in once and actually it's helpful, we can guarantee an appointment to come back and work on a wellbeing plan with someone further. So there's continuity, it's not a sort of just a one-time interaction. And I think this might be my last slide. Just to say, for us, developing the new service is sort of the really positive part, but it doesn't change the need for us to also think about changing some of our existing provision as well. So yes, absolutely, it's great that we're going to have an open access offer and that's new investment. We're also really committed in Dorset Healthcare and with our partners to make sure that we listen to feedback about our existing services as well. So for us, this model brings change in terms of our community mental health teams, which in the BCP patch, huge strength that we have is integrated with social care. That's been a long-standing partnership, but we know that referral rates and demand on those teams is in excess of what we can manage. So we're working to change their offer and to really focus them on the work they need to do. And in addition to that, we've got some new investment in particular into a pathway for people with personality disorders and complex trauma, which has been an unmet need in Dorset for some time. So really positive that we're seeing a really high quality sort of psychological interventions based pathway coming into Dorset, which has been an area of feedback from local people using services that we've had as a gap previously. I think that might be it. So really keen people follow the progress with this as we continue to implement the model, interested in feedback, but there are a number of ways that you can keep track of the model, and equally always happy to come back to HOSC and talk about implementation as we go forward over the next year as well. Thank you, Chair.
Thank you very much indeed. Any questions? Leslie?
Yes, thank you, Chairman. I've looked at all the hubs, which is a brilliant idea. I totally applaud it. But Christchurch doesn't seem to be mentioned at all. We'd have to go to Boscombe. And why would that be?
Yeah, so the hubs do remain under development at the moment. I can certainly take that back to our partner that's leading on the development of those hubs around the Christchurch patch. We did look quite carefully at population data and unmet need in terms of prioritising some of the areas we rolled out to initially. So for us, we knew we had long waiting times in Bournemouth. That was a particular area of challenge for us. But I think it's a fair point. I'd be more than happy to take it back and to provide a written response back to committee.
Thank you. Councillor Matthews.
So a couple of things. First of all, the data we've got here, I can see we've got the initial contacts and the second appointments against initial, and how about half people come back. I'm not sure if that's good or not. You know, I don't know enough about how the service functions if we want more people to come back. But I feel like what's missing here is some of the more useful KPIs that would tell us, is this service working well? How was it working last year? So one of the things you mentioned was it's not a mental health crisis service. I'd be interested to know how often people are presenting who are in mental health crisis, what the outcomes for them are. If we are seeing people who we would have expected to be in mental health crisis now not getting to that stage, if we're able to identify, yep, these 4 patients, you know, last year they would have ended up in crisis, you know, this year they didn't because the service exists. Then just to pick up on what Leslie said, a lot of these the whole approach seems very online and very hub focused, and I just wonder what's being done, not just for the people of Christchurch who don't have one, but for people who aren't digital natives. So for people who potentially, you know, later on in life have severe and enduring mental health and are not going to access anything online. And I just wonder what's being done there. So yeah, data, access online, that's my questions.
Thank you. Okay. So starting with the data one, you're absolutely right. Those KPIs are not the most interesting ones that we have, but it's quite early in the mobilisation to look at the ones that are more interesting. So we're going to be tracking actually outcomes around things like the person reported goals when they start with the service, what did they want to work on, and actually how do they rate their recovery against them as well. So you have clinical outcome measures, person reported outcome measures, clinician reported outcome measures, and those 3 things will be critical to telling us actually what's that impact of the service. Because we're so early, we've only really got activity and NHS England are monitoring activity, but locally we've set a number of additional measures. Again, really happy to share those as we get to the point of having meaningful data samples. In terms of the crisis prevention piece, I think that's probably more around how do you track health utilisation, which I think this is an area we could do that in time, but again, very early in the mobilisation to be able to meaningfully do that and say, actually, have we seen a shift in people presenting to emergency departments or accessing crisis pathways? I think you realistically be talking probably 2 years of data to really understand change in demand kind of profiles. But again, it's something that's within the programme for us to be looking at as a kind of high level outcome. And lastly, so we factored into the job plans of wellbeing coordinators time in the hubs, so physical presence in key locations, digital offer for those that find that most helpful, as well as home visits and time out in other locations like GP surgeries as well. So the hubs are sort of, they're the flagship in many respects, I suppose, of the shiny new thing, but actually the workforce is spread out across the county to say, fundamentally, we need to make sure that those that can't leave their home or maybe struggling to leave their home can still access this service as well, even if they're not online. So that is very much in the capacity of those wellbeing coordinators as well.
Councillor Matthews.
Thank you. Thank you, Chair. I think it's actually a really good concept, and I can see the advantages in the system making mental health provision more accessible and user friendly, because you're breaking down the stigma and all the process against the GPs. I suppose my concern would be, obviously, lots of people, your target audience, if you like, are people that potentially you've no background on at all. So if you get somebody who presents themselves, who's experiencing, who is in crisis, what happens then? Because I suppose that would be, I mean, the coordinators, and I'm assuming they're trained mental health professionals and so on, but I'm just thinking of, like, from the patient's point of view, managing their expectation of what to expect. So I just see a situation that somebody crosses the threshold to actually try and access services, for a lot of people, is a massive thing. So once they've actually made that leap, and then kinds of what happens if they are in crisis, how quick will the intervention be, and how do you sort of go about that process, really? Thank you.
So thank you. I think that's a really helpful question. So the reason that Dorset Healthcare is the lead provider is to help manage some of those challenges. So, we provide everything from your front door open access, relatively sort of low level risk services through to forensic psychiatry. And the reason that we are the lead provider is we can make sure that we've got that connection between a wellbeing coordinator working in Boscombe, that actually they can speak to somebody in the community mental health team, in the crisis team. We've worked really hard, and we've actually had good partner feedback around the accessibility when someone has presented in crisis and we need to get a mental health assessment convened quickly. Those things are happening. We've also factored that into the way we monitor the contract, because it's one of the fundamental tests of, can we easily navigate around our system through this model? And so far we've had some good feedback about it, but it's an area to continue monitoring. Yeah.
I think I'd like to reiterate my colleagues' positive feedback on this. I think it's excellent. I have two questions. You said you haven't got long-term data yet, which is fine, but do you have any sort of anecdotal demographic data on whether you're actually reaching sort of a good breadth and depth of individuals? That's my first question. And my second question is, these hubs are great, but how are you getting people to know that they exist? How are you promoting them? Thank you.
I think most of the anecdotal data we've had has been around the quality of the service. We haven't necessarily broken that down by, so who's coming in and what does that tell us about reach. That could be something that we think about doing a bit more in terms of when we seek that feedback from people. So I think that's a helpful suggestion. We know the age profile coming in, and we know that a good portion of people aren't known to services already. So we are reaching new people, which is positive. I suppose the other anecdotal feedback is you've had people who've had referrals rejected from services accessing this service as well. So in time, hopefully, they won't experience a rejection, they'll just come straight to us. In terms of your second question, remind me, sorry, of your second question.
So just how are you letting the general public and everybody know that you exist? Thank you.
So NHS Dorset, our commissioners have led the comms and engagement programme for the whole transformation programme. We've had a stakeholder group. I think we've got 600 people on the mailing list who want to be kept up to date with developments. We've also been doing a bit of the social media stuff. I was interviewed unexpectedly by ITV to do a promo about it. So we are keeping it in kind of public consciousness. But we can never have enough promotion. So I suppose an ask from me would be, I'd be really keen through all of our various networks to promote the model because it's open access and we'd love to see referrals increase and self-referrals and walk-ins increase.
Can I just ask one follow-up question? I mean, I'm assuming this is the case, but I've worked in healthcare for many years and trying to get people to know what you're doing is a major challenge. I'm assuming that your GP practices and partners are really promoting this on their video screens when people are sitting in the practice, on posters, etc. But also there's lots of other places, isn't there, like food banks. So are you able to get that sort of information out? Just because I just think that, in my opinion, if you just keep coming across posters and you keep coming across stuff, you might eventually go, do you know what? I really do want some help. And everywhere I go, there's these brilliant posters about this hub. Maybe I should just go there and see what help I can get. But actually, as we know, people don't take in information very well. So one poster in one place might not quite reach them. So I was just wondering how you were doing sort of in a more traditional way, going back to the non-digital enabled people, how are you doing in a traditional way to get this? And local press, what are we doing to support people knowing about it? Thank you.
I think there's always more that we could be doing. We've certainly focused on telling partners about signposting people, having BCSE sector providers. Actually, they're networked in places that healthcare won't be, and I think that's really helpful. But we could probably do more promo again. So happy to pick that up as well as an action around just doing it, because we did the launch and that felt really positive. But there's something about going back and consistently, like you say, reminding people and encouraging them.
And do you work with the Homelessness Action Collaborative? Are they aware? I mean, I know homeless services, maybe are accessed in different ways, but a lot of people that are experiencing homelessness or at risk of homelessness are worried about their housing and they've got mental health issues. And so I see in your chart you've got the homeless care team there, the mental health team there, but I'm just wondering if there's linkage into the different partners, particularly the faith organisations like Faithwork, etc. Thank you.
I probably couldn't hand on heart specifically answer about FaithWorks, but certainly as we provide a homeless healthcare service as well, so we're quite networked into the homeless, kind of the wider homeless sort of services landscape. Lack of accommodation is definitely one of the issues that's coming through the door. So staff having to quickly be upskilled and make sure they do know how to support people. But I think, again, it's helpful feedback and another reminder for us of the key places to kind of be socialising this model.
Do you actually have housing officers in your hubs, or is it your wellbeing providers that have to have that basic knowledge and then refer on? Because getting access to housing officer can often be a big deal for people. Thank you.
We will always provide space for any agency that wants to come in and use the space, always. And that's an open offer to all the sorts of agencies on the periphery of this and thinking that it would be good to be based in the hub. We don't have housing officers directly in the team, but certainly the wellbeing coordinators have had a lot of guidance around how do you signpost, how do you know the system, how do you navigate, and how do you practically help someone through that system, not just tell them the same information they may have already. Do you need to go to the appointment with them? Do you need to make the phone call with them? That really practical sort of side-by-side help.
Thank you. I know there are some other questions, but can I just take Betty for the moment? Thanks.
Yeah, thank you. Just on some of your points, Councillor Allen, and just to support what Rachel had said, with the mental health integrated teams that we have, they are our teams within the team with our healthcare colleagues. So there are social workers, there are social care practitioners within that team, and we promote the hubs through that. And Rachel and her teams have kind of provided information, lots of information to all partners, university hospitals, we'll have that as well. And it is really up to all of us as partners, no matter what the service launches, whether it's this or if it's something else that's being launched by another partner, for us to really bring that into the community and use our, our community facing practitioners and officers to be able to do that. So we're all invested in that right across, no matter what the launch of the service is. So we're all invested in promoting the hub's mental health offer. I think just on the homeless point as well. I think that's a really key point, and an area that we're all completely focused on and committed to. What I would say again is it's not always possible to put practitioners of a certain skill into every particular area. You know that, and I know you know that. But what we do is make sure that there is in reach into all of these areas. So, you know, I know that we had something that came on our homeless intervention teams a while ago whenever we were talking about homelessness and our offer and our support offer to the committee before. So I just wanted to reinforce that there is that in reach and there is that access, and we will always make sure that we're able to support where we're, you know, where there is a real need for that. But it's almost impossible for us to be able to put every type of practitioner into every particular area, but that's the whole integration and the whole approach. And I know you do that better than most. So just thought I would add that. Thank you, Chair.
Councillor Moriarty.
Thank you, Chair. I went to the opening of the Boscombe Hub in September. It was great. It was a really warm, welcoming space. While I was there was a couple of care staff who look after care experienced young people, and they did express that it would be very helpful to have something that was kind of specific for, you know, kind of care experienced young people, because they have so many potential kind of issues around housing and all of those things that you cater for. I wondered if that had filtered up to you or across to you or wherever. Thank you.
So I think we could probably do more around once somebody's over 18 and they're a care leaver or they're care experienced, actually making sure that our staff are particularly aware of the challenges that brings, the common experiences people have had, what are the other services to network with. So I would take that as an action, because that's really helpful. Should I keep going? For under 18s, so this programme is for over 18s, and so at the moment, younger people can't use the service. There's an ongoing transformation programme for children and young people being done in partnership with BCP and also with Dorset Council. It's about a year behind this programme, so we're just going through that business case stage to seek investment from our commissioners around an earlier help model, and one of the focus work streams in that has been children in care and young people leaving care as well, because we are aware of the huge health inequalities for that particular group.
Thank you. I'll take the remaining questions and then we'll wind up. Councillor Salmon.
So, am I right in thinking this service will eventually feed into the MHSDS? Is that the right data set? And will we be able to, is the idea that we will be able to see the impact this service then has on, so the community mental health teams, we're expecting that to go down? And is there any indication already from the data you're seeing that it is having a positive impact? Are we able to see from the GP's practices that they're not having a patient who maybe turns up every day, instead they're working with the hub? I was just wondering if we could see that.
So it already flows to MHMDS. So mental health minimum data set is NHS England's requirement around how they measure activity for mental health providers. It's complicated getting non-NHS providers to flow data. We have achieved that. So that's a huge, huge step forward. So we can get proper system knowledge around the level of activity that goes on around mental health. I think it would be too early to draw conclusions around how that's impacted other parts of the system in terms of their activity presentations in primary care, community mental health teams, etc. But they are very clearly built into the specification that that's what the measure of success will be. But as I said earlier, I think I'll repeat my comments around a little bit too early to say at the moment.
Thank you. I'll take Councillor Bagwell and then Councillor Northover, and then we'll wind up, I think. Thank you. Councillor Bagwell.
Thank you, Chair. My question is, my granddaughter last year was going to commit suicide, and we all tried accessing the mental health teams. However, what we kept getting told was, unless she wanted to access it, we couldn't do anything. We just had to wait until it was too late. Luckily, it wasn't too late, and we found somebody that could help her, and she's still surviving and getting stronger. But my issue is that still the case? Does it still have to be the person that's in crisis that has to access it, or can it be a parent, carer, somebody that knows that person? Or is it, if it's still the same, it's pretty bleak?
Okay. So I'm really sorry to hear that, and thank you for sharing that with me, because it's really impactful to actually hear people's stories. That's what drives the need to do this change. That's really impactful. There's lots of sort of things we could talk about around consent, confidentiality, and the Capacity Act. I suppose the simplest answer I can give is if someone isn't in that sort of territory of needing to be detained under the Act, then yes, fundamentally we need their consent to work with us. But with this model, we will support family members, carers. So if someone was talking tomorrow and say, I'm really concerned about someone I'm living with, we would find ways to support that person, even if the person they were concerned about at that moment didn't feel able to access services. And in that way, we can understand risks, we can think about when we might need to intervene with our statutory powers, but that will always be in very few circumstances compared to the majority of the work that we do. But recognise it's really hard for anyone that's a carer to be in that scenario.
Exactly.
Yeah.
Because once you're in crisis, you literally can't think straight. So even though we all knew what needed to be done, we couldn't physically make her understand. And like I said, we found another route. However, my other question is that my youngest child has complex special needs, and is CAMS improved from when she was using CAMS? Because CAMS is brilliant for one issue, if it's depression or you know, I don't know, whatever. But if it's a complex case, CAMS found it exceedingly difficult because they weren't at that point structured to cope. She'd have a therapist for 6 weeks and nothing else would come from that. Well, it takes somebody with mental health issues at least 6 weeks to get to know that person and to open up and to be able to take anything on board. It was good for me, but fighting to get her there was a nightmare. You know, literally having to restrain her and everything else. So for me, I'd like to hope that this is going to be so good that we would be able to bring it out to the younger ones. I do appreciate it's over 18s. And as for the caregivers, I'd like it to be started before they leave care, because in reality, if youngsters are getting issues, they're getting them way before they get kicked out of care. I mean, that's just the way it is. So yeah, thank you.
One of them, well, probably the most important thing to me is that our children's mental health programme progresses. So we're, like I say, we are further behind with that programme, and we're still on more of a journey of improvement for CAMS, recognising that nationally investment's been at about 45% of need. We've got a partnership programme going on. Clearly for BCP, we've got work to do, not just in mental health, but in the SEND space as well. And Dorset Healthcare is really committed to working alongside other partners to address those needs. It's probably the most important thing to me in this job, I would say.
Thank you so much.
You're welcome.
Thank you.
Thank you. Councillor Northover, then we'll wind up.
Thank you. You've already reassured me quite a bit from Councillor Allen's question, but I'm just want to be more reassured, I suppose, that because so many of our services are really overwhelmed, that this doesn't become a place where the service that should be dealing with it doesn't just bump you back there and then you're sort of just going backwards and forwards a bit. And you know, how much is it just signposting? And because if it's signposting to something that maybe somebody's already been to, but I am quite reassured by you saying that people will have several sessions and really go through things. But I just wanted to ask a bit more about that. And I just also had a comment that about care leavers, that we do have the 333 service in the centre of Bournemouth that does all of these things for rising 18 and then over 18 up to the 25 with personal advisors there every week. So just in case people didn't know about that, it is quite well covered, I think. Yeah.
So to your first question about capacity, the business case modelled really carefully the sort of prevalence and incidence of mental health, and actually worked to the 1 in 4. 1 in 4 of us could have a mental health problem at any time. That may be severe, that may be relatively low level from a clinical perspective, but we've modelled to make sure we can cover the ground in terms of the demand. It's probably the most comprehensive business case I've seen, looking at demand and capacity modelling from a population health perspective rather than a specialist lens. And in total, the investment was 3.4 million into this, which in our current climate is quite significant. In terms of the signposting bit, we've definitely heard that before, that services sort of over signpost. And that's why we put in the capacity to do at least, well, it's on average 6 sessions, could be more, could be less. And they will develop a My Wellbeing plan with somebody, so a written plan of support. And someone could choose to use all of their sessions around practical support. And someone might choose to use some of it for signposting. All of the wellbeing coordinators are also trained in open dialogue. It's an intervention that is designed to actually support someone with their mental health. So they're receiving an intervention as well as that practical support as well. And thank you for the further information about care leavers. I can pick that up in terms of just making sure we're networked in with all those other services, because there are services in our conurbation. We've just got to make sure they talk to each other and make it as easy for people as possible to navigate them and get the benefit of them working together. So I'll pick that one up as well.
Just for you, Councillor Allen.
Just one more question that's just came to mind. What happens after 6 sessions if someone's still struggling? Because I hate that sort of cliff edge. Sorry, it just came to mind. Thank you.
So you have to model something to get your investment, but the answer is they'd have more. So there isn't a point where you can max out at the hub and leave. There will be a point where therapeutically we might have a conversation around, if the hubs become the centre of your world, that's not us doing our job. And we've seen that before with some of our crisis cafes. So there's something about the safe transition out, building a life outside of services. But the answer is you would keep coming back if 6 isn't enough.
Thank you very much indeed. Thank you, everyone. Thank you for the questions. And thank you, Rachel, for your presentation. We'll watch this space. Thank you very much. Right, colleagues, we're going to move on to item 9. Is that 9? We're going to move on to item 9, which is to introduce Rob Carroll, who's our new Director of Public Health, who's going to give us a bit of an update. You okay, Rob?
Thank you, Chair. Sorry, rookie error. Thank you, Chair, and good evening, committee members. So yeah, I'm really delighted to introduce myself as the Director of Public Health and Communities. I joined BCP Council on the 1st of April, following the disaggregation of the Public Health Service with Dorset Council. Prior to that, I've been working in a range of public health specialist roles for the last 27 years, primarily working in Hampshire and more recently working in Swindon. But I've actually been a resident in the BCP area for the last 24 years. I've been living in Bournemouth. So hopefully I've got a good understanding of the local area and its many diverse communities as well. So I've been asked to give an update on progress since the last update that you received in your meeting in March. So in terms of progress, just to inform members that the disaggregation from Dorset Council has gone really well. I think it's gone probably better than anticipated and expected. And the new public health team arrived on the 1st of April 2025, which is when I joined the team as well. 17 public health staff transferred from Dorset to BCP Council on that day, and that's around 15 whole-time equivalents. But it does still leave us with some significant vacancies within the team. So I've got about 7 whole-time equivalent posts still to fill, including 2 public health consultants and a head of programmes. The Public Health and Communities Directorate was established from that date. So that includes the community services that were already here as part of BCP Council. So the Community Safety Team, the Community Development Team and the Community Initiatives Team are now part of the new Public Health and Communities Directorate. And we've established now our senior leadership team. We've also had our first team away day session that took place last week to bring the team together and to start to review what our local health and wellbeing priorities are and what our service plan should look like for 25 and 26. So that's still still very much a work in progress. And we have put a joint transitional management team in place with Dorset Public Health. Committee members will be aware that we still have a number of contracts in common with Dorset Council that are still currently being managed by Dorset Council, but with our input into that process too. So we meet every fortnight as two senior leadership teams across both councils to make sure that any immediate risks are being identified and managed. And we also have a joint sharing agreement in place as well for those services and contracts that continue to be shared. In terms of some of the immediate issues, I'd say I've spent quite a bit of time since joining the council, obviously looking at the public health grant that we receive and the pressure on that grant due to increasing demand for some of our public health commission services, and also cost pressures within those services too. So quite a lot of financial work has been undertaken so far. I mentioned the team vacancies that we've got and hoping to start recruitment to most of those vacancies very shortly. Also mentioned about the development of our priorities and the service plan. So looking at the priorities of the Health and Wellbeing Board, but also the corporate strategy and the priorities that have been set out in the Integrated Care Partnership strategy and how we bring those together into a coherent service plan for the service. Also working with our comms team around a potential public health communications plan. And I wanted the committee to be aware that we are due to receive a public health grant assurance visit on the 30th of June. So this is a new style of public health grant assurance that is being piloted in the southwest of England, where the regional director of public health is planning to visit every local authority in the southwest in June and to look at how well we're using the ring-fence public health grant that we receive. And I'll tell you a little bit more about the scope of that visit shortly. Also aware that we currently don't have a health and wellbeing strategy, or I should say our previous health and wellbeing strategy has now kind of run out, and so there's a need for us to develop a new one. And the Health and Wellbeing Board at its previous meeting talked about the development of a strategy into action and developing quite a short focus document about the health and wellbeing priorities that we feel that we can address. I'm also working with colleagues in NHS Dorset looking at the development of our place-based partnership and what we can do to really further develop and mature that partnership as part of wider changes within the system. And inevitably, there's been some issues with our current contracts, making sure that we've got the right paperwork in place and we've got the right payment processes in place, but also having a view towards our future procurement, looking at when those contracts end, particularly those shared contracts, and looking at whether we want to continue to procure jointly with Dorset Council, or where there are opportunities for us to do things differently to meet the needs of the BCP population. And finally, pharmaceutical needs assessment. So this is a statutory requirement on the Health and Wellbeing Board to produce a pharmaceutical needs assessment, which is an assessment of need for pharmacy services within the population. And the requirement is to produce that every 3 years. And so we need to publish our pharmaceutical needs assessment by October 25. And that piece of work has been undertaken, and it's due to go out for public consultation for 60 days from June. And there'll be an opportunity for me to bring that needs assessment back to this committee before it goes to Health and Wellbeing Board in October and before publication too. And finally, just in terms of a bit more detail on the public health assurance visit. So I mentioned it's by the Regional Director of Public Health. Essentially, he will visit Dorset Council for their public health assurance visit in the morning on the 30th of June. There'll then be an assurance meeting with the Dorset Integrated Care Board, and then he will travel over to BCP in the afternoon for the BCP assurance visit. And that will be a meeting with the leader the Cabinet Member for Public Health, Chief Executive, our Section 151 officer and myself. Really, the assurance visit is taking a deep dive into how we use our public health ring-fence grant, which is a grant from the Department of Health and Social Care, and the governance and accountability arrangements that we have in place around that. So there'll be a deep dive into our grant returns for the previous 2 years. We need to submit a budget plan for this year and a 5-year public health budget forecast. And we also need to provide some evidence of impact in terms of the difference that the public health grant has made to the health and well-being of the population. There'll also be a deep dive into the advice that we provide to the NHS and the arrangements we have in place for public health advice to the NHS, because that is a mandated service. And then finally, there'll be a deep dive into the miscellaneous category of spend. So the spend that we're making as a council outside of the key categories within the public health grant. And again, ensuring that we've got outcome measures and evidence of impact in place. So as part of that, we need to submit all of that evidence 2 weeks before the assurance visit. So a task and finish group is currently working on that. Obviously, a lot of the information is held by Public Health Dorset, but we'll be pulling that information together for the 16th of June ahead of the visit on the 30th of June. And then the output of that visit will be a report which we're expecting to receive in September 2025. So that's the end of the presentation for today, but happy to answer any questions.
Thank you, Rob. Yeah, a couple of questions I can see already. Just to clarify what Rob has said about the pharmaceutical needs assessment, this is something which Rob's required to do. So we will find a time for us to have a look at that at the most appropriate time. So that's just to let you know that we'll be building that into the work programme. But Councillor Allen, I think you were first.
Welcome. It's great to have our own public health in the council. I think that's excellent. A couple of questions. First of all, are you concerned that there's going to be any impact in the significant changes coming to Public Health England on how that might affect public health? That's a big question and probably you don't know yet, but it'd be interesting to have your view. And my second question is, I have a background in healthcare, and I think my biggest challenge in the last few years is recruiting good staff and then retaining them, and actually them and not losing the staff that you've got just because they're so stressed because they need more colleagues and they need more help. I think you've got a hell of a lot of vacancies there. I must admit that sort of rang bells with me. So I'm just wondering what you're hoping to do to fill those vacancies with good staff and support the staff that you have while you're waiting to properly recruit and get them in, because that process can be very long-winded. I don't know about you, but I don't know if the council's as bad as the hospital at the moment, but trying to recruit people is like trying to pull teeth. Thank you.
Thank you. Can I answer the second question first? So, yeah, it can be difficult to recruit senior public health staff, particularly consultants in public health, and there's a very set process for doing that is very tightly managed by the Faculty of Public Health. I've actually spoken to quite a few consultants in public health that kind of live locally but work in other parts of the country who've already reached out to me to see if there are any opportunities. So I do feel quite confident that we'll be able to recruit consultants in public health, but hoping to start that process soon. In terms of support for existing staff and stopping them feeling too overloaded, I think that's where the transitional management team also comes in. So currently we recognise that both on the Dorset Council Public Health side and the BCP Council Public Health side, we still have vacancies in both teams. And previously most of those staff have been working across both local authority areas. So where it makes sense to continue to work together, we are continuing to work together. And so, for example, we have consultants in Dorset that are continuing to lead on programmes that cover Dorset and the BCP area. And we're also starting to pick up programmes too that will work across both areas until we've both recruited to our full establishment. So that's how we're trying to manage it at the moment, and obviously engaging staff in the process listening to their concerns, identifying any risks to any programmes based on our reduced capacity, and then putting mitigations in place as best as we can to manage that. In relation to your first question, which was a much bigger question, which I think was around future changes to the system.
I'm just interested in how you perceive that the significant changes in Public Health England is going to impact, NHS England. So my brain's not working today. And how that might impact public health and in our area, really. I know it's hard to say because you don't know till you know, but I just thought I'm just interested in your view. Thank you.
Thank you. Yeah, it is quite difficult to say. I think there's some real opportunities and there's some risks. I think there's some real opportunities with the delegation of commissioning from NHS England down to a more local level. So I think one of the frustrations that I have and that many other people in my position would have is that we've had probably very little influence over the commissioning of screening programmes and immunisation programmes, which have been done on a regional basis to date. And that commissioning is never, is not as sensitive to the needs of local populations, including diverse populations in BCP. So I think one of the opportunities is to have more influence and control over that. So I'm quite happy that we're seeing that being delegated to a local level. Conversely, we are seeing other things being potentially delegated to a regional level. So particularly infection prevention and control, which I can see some of the rationale for doing that once at a regional basis. But again, recognising that our populations are different, our levels of risk in relation to infection prevention and control are different too. But I think there's still an opportunity to influence that and perhaps look for that to be done at a much more local level.
Thanks, Rob. Councillor Salmon.
Yeah, just to draw on what Hazel asked about, because I do think the vacancies ring alarm bells. I'm just curious if there is a definite timeline for filling those vacancies, and I'd like to know if they're having an impact now, not having those roles filled. And then my second question would be about the public health assurance visit, and just I'm curious, has that being planned in for next month, has that thrown anything up? You know, so are there any particular challenges or issues that you've become aware of trying to get the house in order for that? And just how confident do you feel about the fact that it's all going to go okay and they're going to go, yep, you guys are brilliant, you can have the lovely grant and whatnot that we get? So I'd just like to know, 100% Joe, it's assuring, you know, or if there are any risks.
Okay, thank you. I think in relation to the first question, the timeline about recruitment, is it having any negative impact at the moment? I'd say that is quite minimal at the moment because we still have the same number of consultants in place that we had prior to the disaggregation. However, that will change within the next 2 months. In terms of the time frame for recruiting to consultants, it's probably a 3-month process. And then potentially there may be a time delay in onboarding that person. So there will be reduced capacity for a significant period of time before we're able to operate at our full capacity. And we'll do our best working across both public health teams to cover what we can and to prioritise what we need to do. I think in relation to the public health assurance visit, we're still gathering the evidence at the moment, and we're expecting to receive a pack of information from the Regional Director of Public Health, which will highlight potential areas of inquiry. So they will look at our average spend per capita against each public health programme or category of spend and how it compares to other local authorities in the southwest of England and also our statistical neighbours as well. So we're still to receive that information, but we've already started to look at the information where we have access to it. I think one of the areas we can expect to receive some challenge on would be the amount of public health grant that we spend in relation to children's services, where we are an outlier compared to other local authorities in the southwest. And so I've been doing some work with children's services to fully understand how that money is being used, what's being delivered with the funding that we pass through to children's services, and also what are the public health outcomes that that work contributes to as well. But I don't think there's a risk that of the future grant not being received as part of the visit. I think it is seen as more of a supportive visit to make sure that we fully understand what we're spending our budget on, and that we've got clear governance arrangements in place around that spend, and that the public health grant isn't being used inappropriately. And from the information that I've seen so far, I don't believe that it is.
Thank you. Let me take Betty at this point, and then I'll take Anne-Marie. Sorry, Joe, did you have a follow-up?
Just to follow up then, are you almost feeling more positive that this visit may mean they go, oh my God, you guys, you absolutely explained why you spend so much money on children's services. Actually, the demand here, when you look at the demographics and whatnot, actually, if anything, you are not getting enough bang for your buck to address this. Is there any chance that they will increase the amount of funding that we're getting through?
Just saw a pig fly.
I wish the answers to that question would be yes. I think the way that local authority public health grants are allocated is not directly related to the needs of that population, which is a source of frustration amongst directors of public health and other local authorities too. And that is because it was based on historic spend within the NHS before the public health functions transferred to the local authority. So we do see disproportionate levels of funding across the southwest and nationally. There has been a commitment from previous governments to look at the formula for allocating the public health grant, but that hasn't been implemented yet.
Betty.
Yeah, it was just going back on, I think it was Councillor Allen's point where you were asking about the changes announced by NHS England for integrated care boards. And although I can advise there is some work going on at the minute for each integrated care board to kind of consider their action, what their plan might look like. And there is some national stuff going on that's cascading down into a regional and a local perspective. It may be that the committee may wish to invite some of our colleagues from the ICB to come, and maybe that's something that the chair can pick up as well. I know that'll be something you'll be keen maybe to do when the timing is right, and happy to facilitate that.
Thank you, Betty. I did take the opportunity recently to buttonhole Patricia Miller and asked, never lose an opportunity to try and influence the decision makers, but she has agreed to come. I think from her point of view, it's really a question of trying to come when she has something positive to say. I don't think all of the cards have yet been dealt, if I can put it quite that way. So that's still a bit of work in progress in terms of people in Patricia's position actually knowing what it is that they're going to be asked to do. But Councillor Moriarty.
Thank you, Chair, but I don't think I had a question.
Oh, sorry.
If I accidentally put my hand up.
So Denman?
Yes, thank you, Chairman. Mine wasn't a particular question, it was just a comment really on two things that you said, Rob. With the recruitment and everything that's going on, I would like an assurance that it's not going to be a terribly top-heavy organisation chart. In other words, we need, to put it crudely, the people on the ground to do the job, as well as the people up, you said, the senior people. So can you give an assurance on that?
Yeah, I think in terms of our structure, we're probably there's a recommended number of consultants per 100,000 population, and the recommendation is that there should be one public health consultant per 100,000 population. So BCP, we're at 400,000 population, and the staffing structure is for 3 consultants. But of course, I'm a consultant too, so I would say we're 3 plus me equals 4. So I think we're meeting the requirement without being over the requirement. So I think we will be operating on kind of minimal levels from that kind of senior leadership perspective, which will allow us to have more people who are operational and delivering and commissioning services on the front line as well.
Thank
Any other
you.
questions?
Oh, sorry, well, the other part of my question or
Sorry,
comment.
go on, Councillor Husband, sorry.
You commented that we would be compared when this regional director pops up to other authorities in the southwest. But part of the point of the disaggregation is that we're not like other authorities in the southwest. This is why we're so different. In fact, we are leaning more towards the east, in my view. But you know, we get lumped in. Not that I mean it rudely. I'm sure Cornwall and Devon are wonderful, but yeah, it's that really that I'm a bit concerned that we are going to be thought of as a very rural area, and we're not.
Yeah, no, I think it's a fair question and a fair point, and the other bit to mention is as part of the PAT, we'll also be compared with our statistical neighbours. So those are local authorities that share a similar demographic to ourselves, and they're from across England as opposed to just being within the southwest. So our spend per category will be compared to those as well as the southwest.
Okay, thank you, everybody. Thank you for the questions. Thank you, Rob, for that presentation. We'll no doubt be calling on your services at some point in the future, but thank you very much indeed for that. So, colleagues, we're going to move on to item 10 of the agenda, which is the Future Care Programme update. Just for the benefit of new members, this is something that's been on our agenda previously, and we just keep kind of asking Betty to come and give us regular updates. So we've got Betty here, and we've also got Dylan Champion, who's the Programme Director for Future Care online. So who's going to kick off first? Thank you.
Yeah, so I'm gonna hand over to Dylan, if that's okay, Chair, who is going to share the presentation from. You have the paper that we did and compiled, and you've had that. And Dylan is just going to pull up some slides to just talk through the content of what's in the paper, and then very happy to answer any questions. And as Chair's just mentioned, you've had a paper on this before. Not too long ago to some extent, but we committed to bring in regular updates because it is a major transformation programme that is going on within the health and social care footprint within the Dorset area as a county. Thank you. Dylan, if that's okay, I'll hand over to you with the presentation, please. Thank you.
That's absolutely fine, and thank you everybody, and good evening everybody. For those people that haven't met me, and I think I haven't met a number of you before, I'm Dylan Champion. I'm the Programme Director for the Future Care Programme, and so I'm contracted through Dorset Council on behalf of the ICB and BCP Council and system partners to manage the transformation partner and the transformation programme. And so I don't work for Newton, who are our partners who are helping us to deliver the programme. What I thought I'd do in the next 10 or 15 minutes is quickly run through where we are with the 4 principal work streams that form part of the programme, and finish up with an overview of where we are against the benefits targets that have been set for BCP Council. And then if there are any questions or observations, if I can answer those at the end of the presentation, that will probably be more straightforward for everybody. So getting into the sort of detail of the presentation and introducing future care. So future care is what colleagues would previously have known as the UEC transformation programme, and it aims to improve outcomes for Dorset residents by improving the way that system partners work together to support people to be discharged from hospital more quickly, and also to prevent people being admitted into hospital once they attend emergency departments. And the background to the programme, and there's another slide following that, was a diagnostic exercise which was undertaken during last summer, which identified that if partners work together, there's quite a large opportunity to improve services for Dorset residents and to deliver a number of really key outcomes. And for local authorities, BCP and also Dorset Council, what the diagnostic showed was that if we can provide better reablement services and work together to help people to be discharged from hospital more quickly, then potentially there's an opportunity to reduce the number of home care hours that as a system we need to commission by 420,000 per year, which would make a substantial difference to those people, but would also have a financial benefit for those two local authorities. The other significant benefits were the diagnostic identified an opportunity to reduce the number of days that people spent in acute hospital beds by about 27,000 over a period of a year, and so people would spend less time in an acute bed, but also an equivalent reduction in lengths of stay for community hospital beds and local authority care beds, which, if you quantified that, is equivalent to about 100 beds or 36,500 bed days per year. So the opportunities from delivering the future care programme are quite substantial. And where we are now, and just before I get there, and just providing a little bit more information about that diagnostic and how we came to those conclusions. First of all, there was quite a lot of data analysis, and over 100,000 data points were analysed, and a range of different opportunities. But more importantly, there was a fair amount of engagement with residents and patients, and over 166 people from across the Dorset health and care system, from a range of different organisations. So there was a substantial evidence base which informed the diagnostic and the identification of the benefits. And final slide on the diagnostic, I said it was informed by people and views and experiences. This slide identifies some of those experiences, some of those views which have informed the shape of the programme going forward. So moving on to the programme itself, the transformation element of the programme began in earnest in January of this year, and so we're about 4 months into the sort of design and delivery phase, and the programme is structured around 6 interconnected work streams, 4 of which are very people focused or people facing, and they're the alternatives to admission work stream, which looks at people's experiences when they've presented at the emergency department, and consideration is being given to those people being admitted into a specialist hospital board, and in particular it looks at whether those people could go home at that time or utilise same-day emergency services. So that's one of the work streams. The second work stream is a more sort of system-wide and encompassing work stream, which looks at transfer of care processes, and in particular transfer of care hubs, and how the council works with the acute hospital, works with the community hospital, and works with the ICB to make the decisions and to undertake the processes that allow those people to go home more quickly. So the transfer of care work stream primarily focuses on processes and how people get home. And then there are two work streams which are specifically to do with different types of services. One's the home-based intermediate care work stream, and that's the one that's being led by Betty and by BCP Council. And that looks at home-based reablement and intermediate care services. And so are people receiving that really important short-term support quickly enough? And are the right people being referred to reablement? And then when they are accessing reablement or home-based intermediate care services, is the service the very best that we can provide for them? And then the fourth work stream is looking at bed-based intermediate care, and in particular the quality of service that people receive within community hospitals and within local authority commissioned intermediate care beds in care homes. So they're the four work streams that I'm going to provide a bit more information about in a second. But before I do that, it's worth saying that there are two other work streams which are more sort of internal or enabling work streams which help all of the other four. One of them focuses on system visibility and using data and business intelligence to support the decision making better and to enable colleagues to make faster decisions. And then the final work stream, and this comes out of the diagnostic and capturing staff and managers' experience of change, it focused specifically on what do we need to do to deliver change at scale across lots of different organisations. And so the 9,000 people that work in health and care across Dorset are all working in a consistent way and to the same processes and approaches. I want to say a little bit more about the four patient or person focused work streams now. The first one, the transfer of care work stream, this is about making sure that people are cared for in the right place, and that where a person can go home, that process is supported and it's a speedy process, and people aren't moved from one bed to another just to release an acute hospital bed or directly into a long-term residential care bed. And what this work stream has been looking at, and it's the one that's furthest ahead, and that work started in Dorset County Hospital, and there's a little bit more about it in a minute, is it's looking at decision-making processes, it's looking at how people communicate with patients and people, it's looking at supporting wards to start that early discharge planning before people are categorised as medically fit, and it's looking at the tools and tracking and visibility to support that. So this is the largest of the work streams and the one that started soonest. And what's presented in this slide is how it's already beginning to make a difference. And there's an example here of a case study of a gentleman that was helped home more quickly because of earlier and better conversations between the adult social care team and hospital staff and the transfer of care hub. And it's an example of how, if we can set up ward huddles and earlier conversations and multidisciplinary working, what didn't seem possible for Derek suddenly becomes possible, and Derek gets home earlier. So this is an example based on a real life experience which has recently occurred, though obviously the real person wasn't called Derek, and that bit has been anonymised. I said the transfer of care work stream was the first to get going. What this slide does is provide a bit more information about that, and what we can show that in the wards where this work started, what was achieved quite quickly is quite a significant increase in the number of people which were discharged from that ward each week. And what the expectation is as the different ways of working are rolled out across Dorset County Hospital and then across the two acute hospitals within BCP, this will have quite a significant impact on services right across Dorset. What's on the right-hand side of this slide is some of the experiences of people involved in those processes. Now, since this data was captured, and this was based on 3 trial wards, the work in Dorset County Hospital has been expanded across all of the wards now. And so we're just beginning to see the sort of hospital-wide effect, and the work will be beginning in UHD hospitals at the beginning of June. And so we should be able to see it within BCP, certainly within the next 6 to 8 weeks. Second work stream I said I'd talk about was the preventing admissions work stream. And what this work stream aims to do is to look at people's experience once they've been assessed within the emergency department, and where the initial conclusion is that somebody needs to be admitted into a hospital ward for an overnight stay. And in particular, what this work stream is looking at is whether those people could be better supported at home if we were able to more rapidly organise community-based services at home, or whether they could be supported through same-day emergency services, so they get more of their diagnostics on the day or more advice on the day, which would then enable them to go home. And this is a work stream which is being tested and developed within Bournemouth County Hospital as we speak, and will be rolling out at scale over the next 6 to 8 weeks. The third work stream, and it's the one that's been led by BCP, is a really important work stream, and it's looking at home-based intermediate care, and in particular whether, if we look at all of our intermediate care capacity across Dorset and the fairly significant number of different suppliers, whether we can use that capacity and get those suppliers to work together in a different way, where first of all more people are able to benefit from reablement, but also that the service provided is of higher quality or more effective than that they're achieving at the moment. And so there are 4 really key improvement cycles in this work. The first one, P1 visibility and grip. The aim of that is to get good visibility of all of the different providers and where the capacity is and where the capability is. And so when there are people waiting in hospital to access reablement services, that can be done more quickly, so people don't have to wait as long as they might do at the moment. The second the second improvement cycle, best reablement, that involves working with Tricura and Care Dorset and the other providers to establish a more sort of person-centred and goal-based approach to reablement, so that people recover and are reabled more quickly, and so their long-term care packages, if they need ongoing care, are smaller and easier to source. So they're the 2 really important improvement cycles within home-based intermediate care. There are 2 further ones. One is about working with providers to establish a trusted assessor model, and what this means is that if it's successful, we can rely on reablement providers to do some of the initial assessment that perhaps social work staff would do at the moment, so that we can reduce some of the pressures on social work staff, but also we can do those assessments slightly more quickly. And then the final improvement cycle is about improving the process for restarting home care packages when someone has been admitted into hospital, but their home care package has stopped. So really important work stream. It's the one that BCP is leading on, and one which we expect to have a really big impact on Dorset residents. And in particular, once the work stream has been successful, we expect that it will have increased the number of people able to benefit from reablement services each week out of hospital from 50 to at least 65. And we expect it to increase the effectiveness of reablement from a sort of average package reduction size of 4.6 hours to an average package reduction size of 6.3 hours. So really important work stream. Final one I'll talk about briefly is the bed-based intermediate care work stream. And what this work stream primarily aims to do is to reduce the length of stay that people spend within community hospital beds or local authority commissioned intermediate care beds, and to reduce that average length of stay from up to or around 37 days to less than 30 days. And the way that it's going to do this is to work really closely with hospital and intermediate care staff in each of the different locations across Dorset on a through a series of waves. And that first wave, which focuses on Wimborne, Blandford and Coastal Lodge, is actually starting, I believe, this week with work in Wimborne, and it will carry on through the remainder of the year. So they're the 4 work streams I was going to provide a bit more detail about, and I said I would finish by focusing on the anticipated benefits, and in particular the financial benefits for BCP Council, and to provide assurance that they're still in line with the targets and allowances which were set as part of the BCP budget setting process, the MTFS process. And what I really wanted to do was confirm that those net benefits, and so the agreed benefit minus the cumulative fee, is still in excess of what's been budgeted within the MTFS, and will mean that the overall cost of delivering the programme for BCP will be a net benefit rather than a net cost. And so that's where I was going to end the presentation. So I'll take the slides down and invite questions or observations, and hopefully that was helpful.
Thank you very much. Thank you very much, Dylan. That's my hearing thing interfering with the equipment. Betty, did you want to add anything at this point?
Yes, thank you. Thank you, Chair. So Dylan and I will take any questions on that, but I just wanted to remind members of the Adult Social Care Fulfilled Lives programme as well, which is our biggest transformation programme in adult social care. And I think it was last committee that you had a presentation on 2 of the key areas within that. And it's just to remind members that this runs alongside that, but they are both separate programmes with separate outcomes and benefits, programmes of benefits. Both of those will be delivered, but it's really important that we don't double count, or we don't think that one programme is doing it for both, because there are strong commitments and requirements on both programmes. And if and when, I should say, both programmes really come to fruition, we should begin to see those really positive outcomes for people in what Dylan has said, but also those benefits that have been set for future care or for Fulfilled Lives programme in adult services. And you, at the next committee, you will receive a paper and a presentation on that. I'm pretty sure it's that one or the one after. It's programmed into the forward plan. So I just wanted to remind you of that and to connect them both before you may go into any questions. You know, just have that clarity. Thanks.
Thank you, Betty. Just before we do take questions, it's probably quite a difficult question, Betty, but could you just say, in relation to home-based intermediate care, the difference between what it is we're trying to achieve through this programme and what it is we're trying to achieve through Phil Lives?
Oh, sorry. Both programs are connected and will benefit one another, but the Fulfilled Lives programs in adults is very much around that. It's about enhancing the lives of the people that we're working with through a number of work stream areas, similar to what Dylan outlined in the key work streams within the future care. So, for instance, one of the work streams within the Fulfilled Lives program is how we work. So if I just give you an example of that. So that is about changing our culture within adult social care, about how we work. It's about a strengths-based conversation approach rather than going straight to an assessment and a provision approach. It's very much around enabling that person to tell us their journey and their story, and then for us to work with them in a person-centered way that works for them and works for their family. It's also around looking at what is our digital offer. So we're going to be enhancing our web pages, our offer of what people can access through that. We're also going to be looking at our self-directed support offer. And you had some of that whenever we talked about our day service reviews. Do you remember? We came and we talked about the different approaches to how people will be able to use a direct payment to go off and to source things from a wider range of providers rather than have to use traditional providers. They'll be able to do that as well as have an enhanced offer. And they're kind of just some of the examples within the Fulfilled Lives one. The Future Care Programme, as Dylan outlaid there for you, is initially a really ambitious programme around how we transform urgent emergency care within our Dorset footprint, our Dorset county-wide footprint. So that will be very much around looking at how we prevent people who don't need to go through the hospital, going through onto wards and going through into different departments. It's about actually being able to address and pick them up and support them as early as possible. And one of the work streams is Dylan said within this, the home-based intermediate care is very much about bringing all of those pathway one, as it's referred to. So to get people home, services that will help people to get home and to stay at home. It's about bringing them all together and using them in a way that is able to get the best use out of them, but also to develop them into a much more recovery model and a much more recovery approach. At the minute, within the Dorset footprint, looking at just pathway one, we have 32 different routes. Like, that is huge. So this work stream, as Dylan said, I'm the SRO for, is really on picking all of them. And the first part of it is about enhancing our reablement offer. And we touched on some of the statistics around what that could be. So we're working very closely with Care Dorset and our Tricuro. And we're working really closely to get them to be able to fully utilise their services, but also to be really efficient within them and for us to support them. And ideally, what we hope to have within that work stream is an offer where you can have reablement if you need it, and that it's not patchy across the Dorset County footprint. But if you need intermediate care as well, they could reach into that alongside with the reablement, and that you're getting a much more holistic offer for your needs at that particular time. So it's very ambitious. Everybody is totally signed up to it. And I genuinely see that the Future Care programme that we're talking about tonight will absolutely complement and support the Fulfilled Lives programme that we're also working on within adult services. But I would just stress that they are two massive transformation programs, the biggest that I've ever been involved in within this area.
Thank you, Betty. Any questions? Councillor Salmon.
So I think you're absolutely right. It's a very ambitious program, and it needs to be, and I think that's a good thing. I'm just a little worried about the branding because you've called it Future Care. Anything that comes to this council called Future whatever to me rings alarm bells, and I think because of that, I do worry a little about some of the things I can see here, or the lack of, because I can't see in the report the baseline data I'd want to see on bed capacity, workforce numbers and all of that, because it looks like we've got really ambitious targets that depend on us having a workforce, having a care system that can support all of that. So getting people out of the hospital beds and more at home reablement. And it might be that I've missed it in the report, but I can't see where that comes from. I can't see. I can't see where the confidence in these forecasts, which look fantastic, I can't see how you've got there. I can't see that working, and I'd want to see that working in this kind of report. And what I'd also really like to see, because I think it is one of the concerns we brought up in this committee, was the fact that actually this is a very complex program with lots and lots of different partners, more than I think would have been involved in the previous work Newton has done. But despite that, I'd like to see, and we know this strategy will work because this is where it's worked before. These are the demographic similarities, or this is how we transpose this. And I can't see any of that evidence yet. And I'd want to see that when I can see predictions about millions of pounds being saved. So I just wonder if maybe we could have something come back to committee that has that less almost high level or individual story data, because we've got that, which is nice. But I want to see, all right, how have we figured this out? What do we expect in 2 years' time? How many carers are we going to need in the BCP area? And demographically, do we really think that's realistic? Especially given, all the stories in the press about the fact that you're not going to be able to come to this country and get a job in care anyway. So yeah, sorry, there's quite a lot there, Dylan, that I fired off at you, but yeah, be interested to hear your thoughts.
Yeah, if I can come in on those 3 points, and I won't take them in order, but I will answer the three. So I'll take the middle one first, which I think was where has this been done before, and how can colleagues be reassured that it can deliver? And I think there are two elements to that, and so Newton, who are our partner, have done similar transformation programs with very similar scopes in a range of different places, and so most closely and most recently has just completed a program in Gloucester, but they've also completed programs in Leeds, and just on the Gloucester one, colleagues from BCP and from the Transfer of Care Work Team have actually been to visit the Transfer of Care Hub in Gloucester to be reassured. And so Newton can point to success in Gloucester. They can also point to success in Leeds and in Manchester and in Birmingham and in Cornwall. So there is a track record in delivery. I think the second thing I would say is that the programme has been contracted in a fairly innovative way, which is that unless Newton deliver the benefits for each of the organisations as set out, then they don't get paid, and so that provides quite a big incentive. On the question about reassurance and future meetings, where we are with the programme now, I said it kicked off in earnest in January. We've got quite a key steering group meeting on Thursday where we sign off the benefits tracking and benefits monitoring tools and the baseline position. And so we're now in a place where, by organisation and by work stream and by month, we can track whether the anticipated benefits have been delivered according to trajectory. And so absolutely we can bring back an update of that benefits tracking to a future meeting of this committee. And as part of the partnership agreement, and I think it was a requirement of BCP participation, there's also a commitment to come back over the summer with a mid-programme review setting out that those benefits have been delivered on track with the trajectory, so that commitment that the programme be deliver a positive benefit be met for BCP. And then the final bit of the question, which was about the baselining and the detailed data, and what does it look like in terms of bed modelling, what does it look like in terms of future demand for home care, future demand for bed-based intermediate care. Outside of the meeting, if it would be helpful, I'd be really happy to go through that data in detail, because it does exist from the diagnostic, and very, very recently, as part of the NHS operational planning process, and in particular the UHD operational planning process, those assumptions about beds and future use of beds have been built into that operating plan, and I'd be really happy to share that detail if it was helpful.
Thank you. We might well take you up on that. Councillor Allen, I think you were asking a question.
First of all, it's just a bit of a comment, really. I think we're well overdue with trying to offer what I would describe in my service as ambulatory care. That the fact that you can have investigations and go home, the fact that you can be in your own bed and not in an acute bed in a hospital where you can't sleep because it's just too noisy and there's just too much going on, and it's a very scary place to be when you're not feeling well and you just want to go home and go to bed. So I think it's well overdue that this work is being done, and I think that it's very innovative that we're thinking about working in a different way, because I think it's really needed. I am a bit concerned about the big savings that are being promised, I must admit, and I'm with Jo on that. I think I'd like to see where that comes from, and I do think that I can quite understand from the acute hospital's perspective that they want to see a much better flow through the hospital, and I do agree that a lot of stuff could be done without someone sitting in an acute bed, because you can just sit in an acute bed sometimes, and because you're there, things don't happen very quickly. Where if it's ambulatory, then things do often happen a bit quicker because there's a proper sort of process in place. So I'd like to be sure that those savings are coming, but more importantly, I think I'm also with Jo about the fact that it's all very well from the acute primary care, secondary care. We know we don't want people queuing at the door. We don't want ambulances and people in corridors. We only want the right people in acute beds that really need to be there, that are really sick and complexly sick and really do need to have eyes on them. But you are expecting a lot from the community, and have we got the resource within secondary care to really pick this up? And I guess we won't know because you've not been doing this for long, but those are the sort of questions I'd love answered in the future. So it's more a comment on, these are the things that I'd like to know. I'd like to know that the savings are coming, but I'd also like to know that actually the capacity is there to deliver this in the community. And thirdly, it would be really interesting to see what the experience is from the individuals, because I think that would be really helpful. Thank you.
Thank you. Dylan, is that the sort of thing we'll be able to pick up at a future meeting when we have another update on this?
Absolutely, and just on the people experiences, that's something that we're collecting within each of the work streams, and we'll be absolutely be able to feed more back on as we collect more evidence. And also just on the sort of community capacity, that's a particularly important bit of the home-based intermediate care and the bed-based intermediate care work streams, and a sort of key milestone in that home-based intermediate care work stream. And it's something that we'll be able to share at a sort of future at a future meeting, is for the first time we've got a sort of full visibility of all of the different amounts of capacity that is being provided by the 32 different contracts which Betty referenced, and so we're getting to a place where we're much more clear about that capacity than we were if you'd asked us that question 2 or 3 months ago. So yeah, absolutely, we can come back with that.
So just one quick follow-up question. So just going on what I've just said, which is fine, and I'm totally in agreement with it. My only concern is, do we have the safety nets for people that are vulnerable? Because, you know, I don't want someone I love stuck in an acute bed where they can't sleep and they don't feel like anything's happening. And at the same time, I don't want someone that's maybe a bit vulnerable and maybe not able to communicate their risks and their anxieties being sent home when actually they would be better off in a bed. So I know it's sort of like I'm in one respect I'm saying great, we're here, you know, I'm applauding you, but I'm just wondering what are the safeguards and safety nets there for people that maybe do go home because they want to, because you know we all want to sleep in our own beds, but that they are then able to, you know, quickly raise the alarm if they're not feeling well, and that people are aware that they're at home, that they're not well. Thank you.
So I think there are 3 elements to that. So if we start with the person bit of this, which is the most important, what we're trying to achieve through the Future Care programme and through the work streams is that there is more conversation and more involvement of patients in that decision making, and specifically within that transfer of care work stream, that the sort of big difference between before and now is a push to to ensure that those discussions and those decisions start well before somebody is clinically fit. Because one of the findings from the diagnostic is because those decisions weren't started early enough, then often those decisions were sort of rushed, or potentially they were made without full patient involvement. And so that principle of earlier discussions and involving people in those discussions is absolutely at the core of Future Care. And I think in that space, what we will get from Future Care is an enhancement. The second bit about the benefits, so primarily the benefits will be delivered from the Future Care programme by reducing the length of stay in hospital wards, and so that element will be delivered by the programme. How that capacity is used, that will be a decision for each of the individual organisations and conversations between the clinical directors and the operational directors and social care directors at UHD and BCP. And what they've committed to is that, first of all, they want to see the benefits, they want to see the improvements, and then before those decisions are made as to what to do with that capacity, that there's a further sort of check in the process before any significant changes to services are made. And so I think at a sort of personal level, at a programme level, and at a system level, there are those checks to make sure that because of Future Care, we don't end up making changes to how health and care is provided in a way which is detrimental to the system or to individuals on their own. So hopefully that provides some reassurance.
Thank you, Jim. I'm going to take Councillor Salmon and then I'll take Betty, and then we'll try and move on if we can. Councillor Salmon.
So just want to check, we are not being asked to make any recommendations on this report. Are we able to request, because I think Dylan has offered a really useful kind of, we can send you some stuff, and I think that would be good, but I'd almost like to request actually that the next update report that comes like this on the Future Care programme includes that information already. Are we able to make that as a recommendation to, I don't know the right operational way to frame it, but I would like out of this discussion for us to go, this is what we would like in the next report, specifically on future care. Can we do that?
Well, with your agreement, Chair, we'll put that in the minutes and we'll do it.
All right, cracking. I mean, do I need to formally propose that, or are we all happy?
Okay.
All right, I'll bang something out.
Betty.
Yeah, thank you. So I wanted to come back on to Councillor Allen, just on a couple of things. So we will do what Councillor Salmon and Councillor Allen and others have said around the savings and come back and do all of that. We will absolutely do all that for the committee. I just wanted to talk a little bit about the people, because the people are really, really key and really, really important, and that's what we're all here to do, is to make to improve things and to make them as safe as possible. And the key thing around this is around people being able to have what they need in the place that they want to have it. And I fundamentally believe that, otherwise I wouldn't be sitting here kind of doing this with, sharing this with the committee. And I know that's what Dylan and all of the other SROs and everybody is absolutely invested in. It is tough. I could say that it's not, because there's competing priorities coming from everywhere. Not to mention some of the stuff that we heard about NHS England earlier, and how might that, if in any way, influence all of what we're trying to do. But I wanted to just focus on the community side a little bit. So we have, and I know that the chair of the committee is keen to maybe bring something to this committee, ask for something on this to the committee. We have integrated neighbourhood teams. The work that is going on within they're referred to as INTs, integrated neighbourhood teams, and that is very much around how we work with our neighbourhoods. And that is feeding into future care, and future care is feeding into that. So it may be that we want to hear a little bit more about that from the programme person who's leading on that. That is very much focused around people in their local communities and how we all factor into that. Our GPs, our district nurses, our voluntary community sector, our social workers, all of those kind of professionals, and how we wrap around that neighbourhood and that community. And if we get that bit right, alongside this bit right, then we should have much more efficiencies in that we're not duplicating. And from that, we should have more time and more resource to be able to support individuals where they want to be supported, and where it's right for them to be supported. The other thing that I just wanted to elaborate a little bit on was the whole co-production of the work that we're doing. We are absolutely invested in co-production, and not tokenistic co-production where you kind of decide what you're going to do and then go and say, is this okay? Does this look okay to you? And just to give you an example of it, within the home-based intermediate care work stream, we have had one of our Newton colleagues who is, who's done a lot around co-production, work alongside Tricuro and Care Dorset. And once we had permission and consent to go out with them while they were meeting with families and individuals and ask them what their experience was like, actually ask them what, how's this been for you? But more importantly, ask them if they want to be involved in helping us really design this. And I know that within adult social care, when I brought the adult social care strategy here, and we said about the consultation, we had over 100 people say that they wanted to be involved in co-production. So we genuinely, I absolutely want to bring people in to do this with us. And we're starting to embed that in the work streams. So hopefully that would give a little bit of assurance that those people that have had services or are about to have them and their families can absolutely have their say and say what it's like. And then finally, I just wanted to really, really stress that for everybody, safeguarding is fundamental to this. That is the thread that runs along and runs through everything that we're doing. This should not, and you know, if we get this right, will not put anybody in a more vulnerable position. But I understand those tensions. You know, having worked where you work and on the other side and in between both, absolutely, it's hard to navigate. But if you do it and you do it right, then people should not be put at any greater risk or harm. If anything, they should be where they want to be with what they need. Thank you, Chair.
Thank you very much, Patty. Right, if everybody's content, we'll move on to item 11 on the agenda, which is the portfolio holders update. And if I could invite Councillor David Brown, portfolio holder for health and wellbeing, to provide his report, please.
Thank you, Chair. As ever, I looked at the agenda and I thought, oh, a few interesting things, but actually it's fascinating to hear the discussion. Actually, it's really useful for me to hear the questions that are asked and the sort of different perspectives. So yeah, very useful meeting to come along to. Just as my usual sort of brief update, as you'd expect, it's been a lot over the last couple of months since the last meeting in March. Progress on all the various areas that the committee are well aware of, including future care. I just wanted to add to the future care discussion, and it is important that we track the benefits and we can put costs against those, and actually it's important for the accountants and for the medium-term financial strategy that we know the value of the work. But for me, it's also probably even to a greater extent, the value is in the benefits that you can't put a pound sign in front of, and it's actually the quicker, more effective care for people, than being able to be at home rather than hospital, better health and care through the reablement, longer lives, better quality of life. All of those sorts of outcomes is, for me, it's the things you can't put a pound sign in front of are 10 times as valuable. But it's important we get the bits that you can get a pound sign in front of. So yeah, obviously a lot of progress around future care. As was mentioned earlier about the Fulfilled Lives Transformation Programme, as Betty mentioned, and I attended on the 27th of March an adult social care colleagues event, which was very much focused on the Fulfilled Lives Programme, and there were a lot of teams there. It was really useful to hear the initial sort of feedback from people. There was certainly some good anecdotal and sort of qualitative information from some of the teams about how that was bedding in using the 3 conversations models and different way of working. Obviously, public health disaggregation, which we've mentioned, and Rob coming on board, and it was really nice on your first day to meet the team, myself and the leader and the chief executive. We met all of the new public health and communities team and were able to sort of sit down and speak to them. And it was interesting. I think some of them had previously been either Bournemouth Council or BCP and in different roles, and they were based with Public Health Dorset. So for some of them, it's sort of returning back to where they'd been before. So there's I think a fairly positive about the future for that. And I said at that meeting, we had to acknowledge the fact that it'd been quite a stressful time for a lot of them over the last year. And it is for people, if they don't know what their future job roles are going to be, where they're going to be based, what sort of work they're going to be expected to do, who they're going to be reporting into, all of that sort of thing. So it had been quite an unsettled and uncertain time for a lot of that staff. So I think there was a lot of positivity. I think there was a lot of relief, actually, that they got to that point and were in the room and they knew what their job role was, who they'd be working with, met the new director and you could start looking forward. So I think it was a mixture of looking to the future, but also relief that they'd got through to that point. Other continuing work on CQC inspection preparedness. We're just waiting for I know Betty's waiting tentatively for the phone call. And I just wanted to then mention, as well as progress on all of those sort of usual things, it's important to note the Adult Social Care Strategy 2025 to 2028 went to Cabinet in April, which had come to this committee prior to that, and it was approved by Cabinet, including the recommendations that were made from this committee. So I thank you all for your input to that strategy, and it was acknowledged by Cabinet at that meeting in April. Recruitment of the interim corporate director of wellbeing. Interviews were held. Didn't have a massive number of applicants. We didn't recruit in the end to fill that role after Gillian had left. so we're going to be going out to recruitment again, and I think it's acknowledged that if you advertise for an interim role, you are going to have a smaller sort of pool of people to look at. So we're looking at going out to interview for a permanent corporate director of wellbeing. With the timing, that will be useful because actually by then we should have a new chief executive in post who will be able to input to the appointment of a new corporate director for wellbeing. In April, actually, there was a voluntary and community sector event at the Hamworthy Club on transforming health and care. It talked about a lot about the Newton work. It was really, I think there were quite a lot of good conversations, certainly a lot of adult social care colleagues there talking to people from the voluntary and community sector. I suppose I'd have to say there probably wasn't as many people from the voluntary sector at that event as we'd hoped, but I think there are a lot of valuable conversations, and just to sort of get people understanding about what's going on with all the transformations. And again, there's another event this Friday. The Adult Social Care Prevention event is going to be at the Hamworthy Club this Friday, which I love these events at the Hamworthy Club because it's just around the corner from my house, so it's dead easy for me to get to on a barrel bike. Yeah. And I've got a barrel bay installed outside the Hamworthy Club for all the meetings I have to go to, and I can drop my bike outside, so it's, and keep healthy cycling there. And just finally, we've had various sort of ongoing meetings, board meetings and governance meetings with Tricuro. We had one this afternoon, a shareholder governance meeting, and they were very keen to sort of come and present to this committee. And I know, looking at your future work plan, which we'll be coming on to in a minute, although it's not scheduled for the September meeting, I know there were certainly comments about when you looked at the Tricuro strategic business plan, looking at 6 monthly progress against delivery, and that was suggested also for September this year. And certainly if you did look at reviewing the progress against the business plan, I know the sort of new management team, the new chief executive and chair and finance director who are at Tricuro would be very keen to update you on where they are. Things have changed quite a bit, obviously, with the sort of new team coming in. So yeah, they expressed a lot of interest in coming actually and speaking to this committee. So I just wanted to share that with you. Thank you.
Thank you, David. Any questions for the portfolio holder? Okay, thank you very much. Let's move on then to the work plan. There are a number of different kind of bits to this, really. Just for the benefit of the new members, so sort of some time ago, members of the committee decided on the priority areas of all the long list of things that we would like to look at. We picked a list of our priority areas, and we're pretty much getting now towards having completed those areas. And some of them are still ongoing, like the ones that we've just discussed. So there is opportunities, to add things in, and we will see some things added in. It is a working document. It's intended to be a working document. So things like the pharmaceutical needs assessment, we can cover the possibility of inviting colleagues from Tricuro to come is also a possibility. So the document is there, but please don't think it's fixed. It's work in progress, and anything you feel needs to be highlighted, then please just say so. So that's that bit. In addition to the work plan proper, we've also had some requests for additional areas of scrutiny. Some of those are in the paperwork. So there's one from the impact of cuts in or potential cuts in the disability welfare allowances. That's one request. There's another request for us to look at unregistered health care providers. And this was on the back of some national controversy around a company called Lifeways, and also a request from me on arts and culture and the impact on well-being. So all I'm asking, all of those need to be scoped properly. All I'm asking at this point, at this juncture, is to get the committee's agreement as to whether or not you want to put those on the work plan, we will look subsequently at how we might be able to do that. But at the moment, that's all I'm asking you to consider. Councillor Salmon.
Sorry, I tell you what, I should have noticed earlier, but there is another request which is missing from the paperwork on the subcontracting. Oh, okay, all right, cool.
So those are the requests that are in the paperwork. So as Councillor has just indicated, there is an additional request which didn't quite make the cut in terms of getting it out to be included in the paperwork. But we had a request for us to look at a proposal which has hit the paper on a thing called Subco. So this is essentially the creation of a separate company to employ certain groups of staff across the different trusts. So it's effectively a subcontracting exercise. So on hearing about this through the paper, we did make approaches. I made an approach to University Hospital Dorset to let us have some kind of briefing as to what exactly was being proposed, because at that stage there had been nothing. There'd been no indication from the hospital or from the NHS indeed that this was intended. So as a result of a bit of toing and froing, what's happened is that we have agreed with Richard Renault, who works for the UHD, who's been to this committee before, to come and give us a briefing, and really around his diary. We've scheduled that to take place on Thursday, the 12th of June at 5:30, and that's going to be done via Teams. So my intention is obviously to point all of you to come to that, but also my intention is to invite other councillors who I know have received representations about this particular development to also come to that committee to hear what Richard has to say. So I'm hoping that meets with your agreement. Are you content with that, Councillor Salmon?
I'm a bit thick. So that is not the same day as this committee. So that is an additional meeting on a Thursday when we will come in. We will be able to grill this fella on the subcontracting, and we will be able to. It is a separate thing. Yeah. And it's just online. Okay, yeah, I'm happy with that. I think that's probably the best way.
It was a separate date. It's really around trying to get a date that Richard Redden was able to be here, and we're very much working around his diary and trying to get the earliest date possible that we could. So that's why we fixed on Thursday the 12th at 5:30, but it is a separate meeting and it will be on Teams, but you will get all of the details in due course, and I'm hoping that you're content with that. So in terms of the other items that I've mentioned, are you as a committee happy that we include all of those on the work plan? Councillor Salmon.
Sorry to be a pain. I've realised Thursday the 12th is planning committee. Is this going to be a daytime meeting or an afternoon meeting?
It's 5:30. Okay. I'm so sorry about that. Is the committee happy to add those items onto our work plan, and we will come back at some point to determine how, when and where we might be able to look at those particular items. Okay, thank you. As I mentioned earlier, all of us will need to be scoped out a bit more.
Yeah.
Do you want
to take them individually, or is everyone happy to add all of them? Yeah. Okay.
Yeah.
You okay?
Yeah.
The only other thing I wanted to just make you aware of, and Councillor Rigby mentioned this at the Environment and Place Committee a few days ago. Some days ago, the chairs and vice chairs of all of the overview and scrutiny committees met with Democratic Services and with Lindsay, who's the overview and scrutiny specialist. to talk about the pressure that is on Democratic Services colleagues around the use of subgroups, working groups. Whereas before we were looking at kind of restricting ourselves almost to one working group per committee, kind of per session. The indication was that there wasn't really going to be the capacity going forward to do that. So one of the things that the chairs and vice chairs looked at was the issue around the budget working groups that we had last time, and a kind of understanding that there was not going to be the capacity to be able to do that again. So we've been on a mission to agree between ourselves a different approach to budget scrutiny, which will look at the budget more holistically if we can. However, that is not to say that we will not be looking at the budget in relation to adult social care in this committee. And I've made that point to my colleagues that there will be an expectation that we will look at the ASC budget here, and in children's there will be an expectation that they will look at the children's budget also. So it's not that we're going to lose our opportunity to quiz the appropriate officers about the forthcoming budget, but what we're trying to do is to look at ways of looking at the budget more broadly and seeing if we can influence decisions, outcomes, priorities within the budget. So it's just to make you aware that we will be doing things slightly differently, probably on the basis of some agreement between chairs and vice chairs of the scrutiny committees going forward. So is there anything else that anybody wants to, Councillor Allen?
Sorry, maybe I'm being a bit dense, but I don't quite really know what that means. Can you sort of perhaps spell out in a little bit more detail? We are going to be allowed to have subgroups and scrutinise, but we're not, and we are going to be able to look at budget, but we're not. Sorry, it's not very clear. I don't really know what you're saying. Sorry.
We will still be able to have working groups. What the limitation will really is just built around democratic services resources. If we feel there is an overriding need to have a working group on a particular subject to look at a deep dive into a particular subject, then the idea is that will go to the chairs and vice chairs of the overview and scrutiny committees, and we collectively. The idea is that we collectively will make a decision on what those priorities are. So what we're trying to get away, what we're trying to achieve, I guess, is to try and determine what the priorities are across all of the overview and scrutiny committees, rather than a particular niche subject which might exercise our minds here.
And you'll be fighting very strongly for us.
I can't hear you.
Of course.
No, I like it. It sounds a good idea, so it sounds like better use of resources and all of that. I was just reflecting on earlier, been on this committee 2 years, and I feel like we don't have a massive impact still. I might be wrong, but one of the things I think we sought to address a while ago was the quality of reports coming to this committee. And I've been really happy with all the reports that have been presented tonight, all the speakers and so forth, but I do feel like we still haven't got consistently the right data, and I would just like us to formally minute, and maybe if we can formally request for when the ask goes out for these reports, that they're set out with really simple performance data, just really straightforward, where we were, where we are now, where we plan to be. And that is something that we don't get in any of the reports still after 2 years. And I would just like us to maybe reflect on, it'd be nice if we could do that. And for that to be formally set out, we expect this. I expect when a report comes, especially when it's an update, for us to be able to relate it back to what was presented before, which we don't seem able to do at the moment. It always seems a fresh, new, very PowerPointy, very pretty, a lot of good information in there, but not that baseline data.
No, it's a timely reminder, because we did spend a lot of time creating a kind of detailed what was it called, Jerry? I can't remember what it was called now, but you know what I mean. a way of ensuring that we assessed everything against the data that was available. So it's a good reminder that we need to do that. So thank you, Councillor Northover.
I'm just wondering if we could have very informal working groups that are organised, self-organised by the councillors, where we just, perhaps 2 or 3 of us want to meet with 2 or 3 officers, we ask our questions and then report back afterwards to the committee, so that we're not using up the resources.
Yeah, no, that's a very good point, and something that we've been discussing actually amongst chairs and vices, but also elsewhere, to try and almost adopt a rapporteur type approach. That's been an example of it used in environment and place. So we might want to try and do that on subject. I think you have to pick the subject quite carefully, but I think it's doable, and I think it would help overcome the pressures on democratic services. So yes, definitely we'll look at it. I think it's about identifying the right topic and ensuring that we can do it effectively and in a way that's transparent enough for people to see it and ask questions about. Is that okay? Thank you. Anything else on the work plan? We don't have any other business, thankfully. Everybody consent? Thank you very much indeed for your time. Thanks everybody for attending.